let's jump in here. So our three kind of primary experts for today are Justin Stiver, who grew Total Therapy Florida from 1 to 7 clinics. We've got Ben Galin, who's got over 30 years of experience and the owner of Evolution Rehab. And then we do have Daniel Hirsch, who's a therapy compliance expert, and he's the owner of Risk and Compliance Analytics. On top of our usual gang, we've got Tony Maritato. Tony, you can give a little intro, and then we've also got Rafi as well. So two other experts who have lots of knowledge. Tony, if you want to give us a little 30-second intro, that'd be awesome.
Yeah. So my name's Tony Maritato. I'm a licensed physical therapist, private practice owner. I kind of focus on just outreach and answering questions, helping therapists better understand Medicare and get started in private practice. But I do treat patients. I'm still in the clinic. I'm treating, a couple patients a day, every day. So
awesome. Thank you, Tony. And then Rafi, if you want to give just a little intro as well, that'd be great.
Sure. I'm Rafi. I'm an OT by trade, own a practice here in Augusta, Georgia, host the Better Outcomes Show. I do a bunch of consulting in the healthcare tech space.
Awesome. Thank you. So let's start here. The whole topic here is CPT codes, maximizing billable time, bulletproofing documentation. I think, Justin, let's start with you because you gave some really good topics for this, but the first big thing that I want to just cover is maximizing billable time and setting up your schedule to do that. Will you just give some tips on how you approach that at your clinic and maybe mistakes that you've seen other folks make in this space?
I have a hard time commenting on what other mistakes people make just because I haven't, seen their schedules and see how their business works perfectly. But I can kind of talk about what we looked at and what mistakes I think that I still made. Probably make some, but we it's just such a different thing for each business and each clinic, the way that you staff and the way that patients and your patients and the demographics that you see really have to look at everything. And for me, it was making a bajillion Excel spreadsheets, and going back and forth between schedule and how we book and schedule and code and what other services you add. So if you're doing dry needling or if you're doing on top of that, and you have to that's not billable, then or something that you really have to look at your schedule and say, how can I get the most timed units in the minutes that I have, and for each, and if I push it directly to the minute, is that going to mess me up because my quality of care may be changed a little bit? Do I need to leave myself a little bump there to make sure that my schedule's just perfect all the time? There's a lot of factors you have to look at, and sometimes you just have to test something and see how it performs and see if you can go back and find some historical data and then look at it and then change something and kind of try and isolate a little bit at a time to see if that what your average revenue per hour is and per visit is, because ultimately that's what it's all about now, and that's just maximizing your billable time. So inside of that, then you have all your coding, which I'm sure we'll talk about later, but it's still a work in progress. You have to look at it and say, if I have hour slots and someone cancels, then what am I going to do with my therapist for that hour? Am I going to make them clock out? That didn't work well for us. But or I can overlap every 30 minutes. And if someone that happens to, then I can extend that person out to that hour slot, and I can mitigate it that way. It also depends on how full your schedule is. So if you're treating people in 30-minute slots or 20-minute slots, but you don't have a full schedule that day, then you're missing out on potential units billed. But if you're on a long wait list and you're having people find another clinic to go to because you're booking hour slots only, and you can 8 patients per therapist, then you're also losing revenue there. So it's also something that if you really dial this in, it could maybe become big. We are actually very seasonally at we could change maybe by that too. So maybe we open it up during the off season when we don't have the visits, and tighten it up during season. So
Yeah, no, that's awesome. Ben, any thoughts on maximizing the billable time, kind of alternating your schedule as well?
Yeah, I mean, there's a couple things. I think Justin nailed it from all the points he brought up. So, I mean, I don't have anything to add on that point, but the part I would say is most people I've talked to lately are understaffed and can't deliver. Can't get patients in, can't get them in the time they want. Every patient wants 5:30 maybe in one of your regions. Everyone wants 8 in one of your regions. You only have so many therapists. You can't stack 9 therapists and then have no work for them to do at 12. I'm a big believer, again, with the star next to it saying demographics, type of patients, etc. But I'm a big believer in the 2-unit visit these days, and I think that 2-unit visits open up a lot of opportunities to maximize your schedule, gives you room to get patients in same-day evals, gets you the least amount of MPPR ramifications against your billing. Cancellations don't hurt as much. The time ratio of what a patient feels like, hey, that wasn't so bad. It didn't take a lot of my day. You don't get caught in the oftentimes providing low value service when you're just trying to fill an hour, compared to just knowing that you only got about 25 minutes to really nail it down. So, but to Justin's point, if I had a slow clinic and no one was there, let's book out 5-unit visits for everyone kind of thing, So I'm much more of a believer of like a 2-unit visit these days, but I'm also a believer of like, when you say maximizing your schedule, is finding out what your schedule demands. Am I always slow from 12 to 3? Well, if I am, does it even make sense to be open then? If I get a 50% cancel rate Fridays from 3 to 7, does it make sense to be open then? Does it make sense to find a therapist willing to work Saturday morning? Does that get a really good traction and uptake? So I think finding what your market wants. My first job we started seeing patients at 6:30 in the morning in Northern Virginia, right near Paul, within miles of your house. And we saw our last patient up until about 9 o'clock at night. And then we had these staggered schedules for therapists. Like I'd get home at 12 in the afternoon after working a full shift, or go in at 3 o'clock in the afternoon, depending on the day. And we were jammed for the people who, before they went into DC, they saw us and then left. We were jammed from 6:30 to 8. I mean, I don't want to tell you how many patients I was treating. And then at night from 6:30 to 9, I don't want to tell you how many patients. We didn't allow evals during that time, but we were seeing a whole lot of patients. So I think it's recognizing what does your marketplace want and need, staffing accordingly to that. And then if all things being equal and it's the right demographic and right population, the timing's right, I believe in an effective 2-unit visit.
Any questions on the billable time from Greg, Jack, Dwayne? Anyone have any specific questions that maybe something they're facing in their clinic that you'd like help on?
I don't think so. We're still one of the few clinics that does hour-long visits, and it works for us. Because we do that, we have fairly low cancellation rates, but it does happen. But I'm open to. That's why I'm on this call, because I'm looking to maybe consider other options as well. If it's somebody recently suggests to us, maybe we do a 45-minute visit and have a little bit of overlap in patient care. So I'm kind of just looking at kind of expanding some other options possibly.
Yeah.
I just out of pure curiosity, just to dig into that deeper, when you say the low cancellation rate, because I mean, I've heard some people say low and then it's not that low. Like, what
Right.
do you know what the cancellation rate is offhand?
I couldn't tell you the number. It's pretty infrequent for us.
Like one a day kind of thing.
If that.
Yeah. Okay, that's a good cancellation rate.
Yeah.
Tony or
Yeah.
Pete?
So,
Yeah.
hello?
Go ahead, Dwayne. Sorry about that.
Dwayne. Yeah. No problem. So what we've we just moved to like unit based as far as billing, as far as how we compensate the providers, and what could we have our cancellation rate, it's probably like maybe 20. I mean, it's not too bad. I guess like 25%, something like that. But what we have, one of our physical therapists, he double books certain slots. So in the event of somebody canceling, so we have 40-minute slots. We open from 8, so Monday to Thursdays, 8 a.m. to 6 p.m. we close, and on Friday we're 8 to 12. But he'll book, he'll have the the front desk staff double book maybe 3 of his slots. And what happens is if somebody does cancel, then he has somebody in, that's gonna be available to be seen in that slot. Now, if both come in, then hey, he's gonna see 2 people. But that kind of helps with the cancellations that we were getting, where he gets no compensation for people not coming in, because especially during people get we get a lot of cancellations from illness, and we have a lot of, so we're in a military community. So what happens is that if the spouse is not available, as in the soldier is not available, then and usually the spouse is canceling because it's a 1-car family, or they have somebody has to take care of the kids, and so they can't bring, so it's a lot of cancellations from just kind of like a availability to make the appointment. So double booking has actually worked for him, to kind of take care of any slot. If somebody say was to cancel, then he does have someone to fill that slot.
Sure. And Dwayne, what's your, just to be clear, what's your specific question on that? Are you asking about double booking specifically?
Like it's is anybody doing that out there, or it's just like I said, we have 40-minute slots is what
Sure.
we have.
Yeah,
I
think
would
we
say,
can.
I would say it depends a lot on your mix too. If you're seeing a lot of Medicare patients that you may not want to double book at the same time. Maybe you do want to, but it becomes another layer of complexity when it comes to your scheduler as well. And also, most of the time you're going to want to communicate with your therapy staff to determine whether or not be a patient may or may not. I know we have a lot of total knee replacements, and maybe we have maybe 20 or 30 per day in our whole organization coming in for emails, and patients could easily be double booked from a treatment standpoint. But I found that a lot of times you have to weigh that into it. So what I was going to say is you have to also look at level of complexity that you're putting on to somebody else in your organization to schedule these people to.
Yeah. We've got
We always try to keep a little bit of a waiting list. So if we have cancellations, we have usually kind of people we can reach out to call to kind of fill those spots in. So that's kind of a big part of our strategy is, I might have misspoken, we have cancellations occasionally, but if we do, we try to fill those spots on the schedule with the waiting list, which is kind of.
And we measure that metric as, we call it missed opportunities, which I love talking about that, because like I said, if you have a wait list and fill it with a patient, then it's very not to your financial status. So if we have a time slot where a therapist was being, there's no patient, there was a patient being treated for in that time slot, then we that metric and as well. So smart.
Two things. One is, I think it's Dwayne that was just talking that he's paying the therapist per unit. That's always nice when you can get that down, where if you're paying, you've got revenue coming in to offset that pay versus salary or hourly. So kudos there. I know a lot of therapists are resistant to that, but the ones who are like, I want more pay, one of the negotiations is I can get where you can make more per day, but you need to buy into this risk model where you're not getting paid if I'm not getting paid kind of thing. And some therapists bite on that, some don't. For people who do have clinics where they're doing a lot of, I haven't done in a long time, but one of the clinics I was at that was really busy and really booking. We assigned, because we couldn't go up to the desk every time someone wanted to schedule, like, oh yeah, you could put Mrs. Smith with Mr. Jones. That's just crazy to think that like we have to go up every time someone wants to schedule. We didn't want to schedule. We came up with a point system. I don't know if anyone does that, where you assign 1 point for a pretty easy patient, 4 points for someone who needs a ton of hands-on care, and then you tell the front desk like I can only have 4 points in a rolling hour. So just, and we put on their chart, we actually put in the record that there are 2 or 1, and they could change. Someone could go from a 4 to 2, and it just allows them to be able to book without having to call the therapist in to say like, can I put this person here? Well, no, if I've got a 4 there, no, you can't, and you shouldn't have to ask me.
Yeah. No, that's a really good point, Ben. Tony, any thoughts on your end, or Rafi as well? If you guys have any, we can. If not, we'll move on to the next topic here.
Yeah, I'm not sure if we actually talked about the topic you mentioned, because you were talking about CPT codes and we went down patient visits. But talking about patient visits, jumping on to what Ben and Justin already said, I would say a layer here is we have to understand the culture of the team in the clinic. Like I've had multiple clinic locations. Each clinic location has a very different feel, very different culture. Some of my clinics, those therapists are never going to see multiple interactions and have multiple patients. If you put me in a clinic, you could book 6 people an hour. I will optimize that hour to get the highest reimbursing CPT codes for the right people with the right supervision and done compliantly. And I'll be like, I'll love it. I'll eliminate MPPR. I'll eliminate all the other, garbage that comes with a dedicated 4-unit 1-hour visit for one person. But I couldn't expect somebody working for me who doesn't have my kind of personality to do that. So we've kind of followed this framework where we really do customize, which is a headache if you're going multiple locations, but the scheduling process to the therapist, or at least the clinical team for that location. And then from there, we look at our conditions, like what are we treating? When we were doing a lot of non-post-surgical low back pain, we had a ton of cancellations. I couldn't do the things in that environment, treating that demographic, that I could do now, like Justin said, with total knee replacement. So once I realized that I'm going to move away, I'm not even going to accept any referrals for back pain. My attendance went through the roof. I had lots of more flexibility in what I could do from a scheduling perspective. And then also, as we consolidated from 5 locations to 2, really now, 1 full-time, 1 part-time, I've got 1 team, and we all are very, very similar in culture. We'll see anybody that walks in the door at any time. So I can have 3 people. I can generate billable codes that are in a compliant manner to optimize reimbursement, but that's only because of the conditions we're treating and the team that I have in place.
Yeah. Tony, you brought up something that wasn't the topic of this conversation, but I just wanted to hit on it a little bit more. I go to plenty of conferences and talk to plenty of people, and I hear plenty of the same thing, which is like, oh, I couldn't possibly, my therapist wouldn't let me do that. My therapist wouldn't do that. At some point, being the owner operator of your clinic, at what point do we say, look, I need you, I like you, but I need you to, instead of you fitting to their culture, at some point, does a therapy culture need to fit to the practice culture? And my question to you is, have you or anyone on this call had to kind of draw the line between I'm bending so much to what my therapists want and say, like, I had a therapist come in and said, I'll only see, 1 patient an hour. I want this break during the day. I want an extra 2 hours of doc. And it's like, okay, then maybe you can go next door and find a place to work, because it's just not going to cut it here. So I'm just curious, when you're saying, and other people on the call, bending to people's wants and whims of the therapist, at what point do you draw the line in the sand and say, well, this is how our company operates? And, have you gotten away with that, or do people walk?
I'll tell you
real quick.
Perspective real quick, and then anybody else can answer. That's why we went from 5 locations to 1.5. because I had the model in my head that this is a successful model. This is what I'm going to hire you to do this job. And this is the job that I expect. These are the expectations of the job. This is what I want you to do. And what I realized over the first 5 to 10 years of practice was I don't have the personality to enforce that. I don't have the desire to enforce that. There are other ways for me to make money that are more enjoyable. So I said, I'm not going to scale to 20 locations. I'm just going to either let everybody go that doesn't want to do what I do. Hence, that's why we're down to like 3 clinicians now. And I'm going to take the business in a different direction because I don't want to enforce my will on the people that I employ. But it's a totally reasonable model. I mean, I love the idea. I just know it's not within my personality to do that. And that's why even, you know, going between Justin and I, Justin has scaled, Justin's done amazing. I know that I don't have the desire to go that direction. I think both can be successful. I went the other way.
Totally. Daniel, did you have something to add there? Sorry.
Yeah, I wanted to address Ben's great point. I've had the pleasure of working with, you know, mom and pops and very large corporate entities, and it always starts with the same conversation. It's about education. So it comes down to, is this individual who is maybe not fitting into the culture, are they educated about what we can and cannot do? So the one thing I didn't hear yet is really great strategies from Justin and even what's working with Greg, but is it allowed in your state, right? So what does the Practice Act allow? So the answer in California is very different than it is in New Jersey versus in Maryland, right? So it really depends where you're located and how you can utilize staff appropriately. So Tony, you mentioned compliant. There's a lot of ways to do it right. And equally, there's a lot of ways to do it wrong. So that's why when you do have to give a tailored answer to maybe Ben or Justin, it really comes down to where you located and what tools you have available to you. And once staff are educated on, hey, I'm allowed to do this, and this is how I can do it, right? That usually sets people up for success because it really, you can't just get a blanket answer just from across the country because it really does depend where you're practicing.
I'll tell you what we do. We have, the expectation is to keep patients happy and provide good patient care. And I pay my therapist, per visit, per patient that comes in. So they're motivated to keep that patient happy and be a good therapist. And if they do, that patient returns and they come back. If they don't come back, that's kind of a reflection. If it's repetitive, it's a reflection of the therapist. I actually had to let one therapist go because I really wanted him to work out, but his patients weren't coming back. His cancellation rates were way too high. So he wasn't meeting that expectations. Patients weren't happy. They weren't seeing value in his therapy. So they're canceling. He wasn't making the money he wanted to make. It was no loss. It was a loss to me as well. And so that therapist and I, we both kind of agreed that this wasn't the best setting for him. Like he didn't have the personality to draw patients in. He was a new therapist, didn't have quite the skill set that he needed for my kind of practice. So we just agreed he needed to go to a place where he was going to get a salary, get paid regardless. But at our clinic, we just that's our approach. The therapists, are kind of they are motivated, to keep their patients happy because it is also not only affecting their patient care but their salary, how much they make.
Greg, where are you located?
We're in Austin, Texas.
And what is your payer mix as roughly? What does it look like?
It's pretty mixed. It's I want to say maybe 40% Medicare, and then just kind of we don't take Aetna, but the rest of the commercial payers, some LOP, not much workers' comp. It's just kind of mixed.
And the reason I ask is because I find a lot of times you have to combine payroll, your metrics with metrics and kind of create some sort of customized spreadsheet or some way you track to see because a lot of times that will help. That's helped me guide me into saying how to treat patients. I want to treat them one-on-one for an hour. How do I have to pay my team and do those metrics work? Because I think a lot to do. It also has reimbursement per visit or per hour as well. Maybe the choice is if you're giving that high quality of care, maybe in your are looking at maybe some of the lower payers and knocking them off and trying to replace them with some higher payers and into that.
Yeah, that's why we dropped that.
Okay.
Yeah. No, that's a good point. There's things that need to kind of factor in. We may have to drop Cigna and some of the others as well, because you're right. And some of these companies like United just want to do a flat rate. I mean, the reimbursement's still low. It does kind of kill us. I mean, so financially, we could do a lot better, but patient care is good.
It doesn't matter much when you're not on a wait. It matters some, but when you're on that wait, you start looking at this potential, lost revenue that you have there. We started in 2018, and we got up and running for a couple of years before all the cuts started coming through every year for us. But we did that. We started dropping low payers in the Cignas and UHC flat rate payers. We started dropping those every 6 months or so, and we were able to bring our average reimbursement in 2018 was $96 a visit, and all the cuts after Medicare and the PTA cuts we're now $1.50 more than that.
And I'll just put a plug in for him for the state of Florida. Most people in Florida, if you ask their average, it's somewhere between $54 and $63 average case weight. So just to give you an idea of what Justin's been able to do, that's pretty substantial lift over the typical Florida reimbursement.
Yeah, so it's a lot different than that in Texas.
Yeah, and that's why it's hard to have these conversations amongst people in different locations, and you really have to understand the metrics because I was talking to someone in Alaska, and they're $186 a visit, and I'm like, oh man, that's a big. But I have to pay my therapist a lot of money. I'm like, well,
right.
Your therapist doing 2,000 visits a year, and you're getting $90 a visit more than us. I mean, I could pay my therapist a lot more too, so it's different. It's apples to oranges. And I think my advice is on the back end, you really have to understand your metrics when it comes to financial and payroll and costs and everything. And so, or else you're kind of theoretically talking about this, assuming that the person that you're talking to has the issues as you have, and we never do. So.
Right.
We've got a specific question here that was submitted beforehand that I want to get answered. And I'm just going to read it off here, and we'll get everyone's opinion. But it says, we are billing 55% of all of our CPT codes as 97530, focusing our practice on activities, but only 3.3 units per visit on a 40-minute schedule. How can I bill more units per visit?
On a 40-minute schedule?
Yeah, 40-minute schedule, only 3.3 units per visit. Yep, on that 40-minute schedule. How can I bill more units per visit?
They're already 0.3 units over. I'm confused by the question.
I would say, what is your AMA? Yeah, what's your AMA versus insurance type? How much? Yeah, that also matters a lot here, because you can get 3 units in 24 minutes with certain insurance.
Not if they're billing mainly one code.
Yeah, if they're billing the same code, then you're looking at obviously more, but you can still do it in less than 40 minutes for sure.
Got it. Okay.
So I guess
what is the breakdown?
If it's an 8-minute follows Medicare guidelines kind of thing, you've got 38 minutes as your bottom floor, and to try to get in 3 units. So to get in, and you have 53 minutes to get your ceiling. So I mean, for someone to be getting 3.3 units, if that is their heavy case weight, congratulations. I don't know where they're fitting that in. But to what Justin's saying, if it's an AMA contract and you've got more of a unbundling each code, and you just did 8 minutes of Therax, 8 minutes of Therac, 8 minutes of manual, and 8 minutes of gate, conceivably you've got 4 units in a 32-minute span. But I've noticed that every year more and more plans to say we're following Medicare rules. My AMA plans went from probably 50% of my plans down to 0.5% of my plans.
Daniel, I want to ask you a specific question on the just making sure that people are compliant with their billing. Will you just give us some tactical advice for folks out there on things they need to understand when it comes to risk and compliance for billing specific codes or just billing, specific situations?
Yeah, the first thing is don't do what this question just asked. Over 50% of your billing at the highest reimbursed code right now for one-on-one codes, not recommended. It's an automatic red flag to any payer. That statistically that should be more in the 25% range, maybe 30% of your spread, right? The big four, 530, 110, 112, and then obviously manual. So the idea is that you do want to diversify. I mean, Ben, to your point, the 8, right? Stacking up 8 minutes for 4 different codes. That is a strategy. People take advantage of that all the time. And the trick is, are you really doing that, right? So you want to make sure that people are actually reflecting the services that they're providing. And that's really the take-home message that anyone should be worried about is your billing reflective of what the skilled services are you're providing? So for you, Ben, if you're only doing, 2 units a visit, you got to be pretty dead on. You only have 2 to work with. I like diversifying it. I think it helps. That's really kind of the problem that we see across the industry when people are just cherry picking the highest reimbursed every year and then just modifying, right? Because the codes get adjusted every year. So people just keep shifting and then we keep seeing adjustments. If people are using 116 for gate training or 535 or 537, these are great things to add. Even the 3 new, what are they called? Caregiver codes for this year. We need to be using these. If you're doing modalities or not modalities, the group code as well is a fantastic code. So these are things where we want to see that it's all statistics, right? The only reason that we're seeing problems is when people are billing like this, 55% on one code.
Tony, we'll go to you first, and then Ben, we'll get to you.
Yeah, and to build on what Daniel's saying, and Daniel, you can talk to this better than me. The definition is an average of 15 minutes. So if you're only exclusively ever doing 8 minutes for every CPT code, even if you're going across multiple CPT codes, there's still some concern there when it comes under review. I don't hear enough people talking about that part, the average 15 minutes. But go ahead, Ben. I had something else in my head, but I lost it after.
A couple things to just piggyback off Daniel here is one. I got a little in my hand. One is, I used to make a living off getting people off of focused medical review, and it's been a long time since I have. But I'll tell you, your data, everyone, my documentation. Well, yeah, if your data flags, your documentation will get read. You'll get a cert looking at evals because they're suspicious of your eval codes that have diagnosis codes that seem pretty weak. So I would say one thing is just knowing your data. Like I've had a CBR before, which is said, hey Ben, you do a lot of manual therapy. Like you're the number 3 person in Florida doing manual therapy, whatever, which is an alert to you, basically saying like that's a statistical anomaly unless you got a really great story to explain why. And your documentation doesn't hold up. Like you're probably swimming in a lane where someone's gonna start looking at you if your overall macro data is also bad. Meaning I'm the number 1 billing orph in all Palm Beach County. My macro data is already looking like a large fish. I do like a crazy amount of 535s and my data. So just knowing your data is important. Understanding how your data paints a picture of your clinics important because people spend so much time worrying about documentation. I'd say worry about your data first, and then worry about your documentation. But to answer some of the questions that were asked here, the codes that raise flags, because like I said, no one reads your documentation until your codes reads a flag, has to do one with your ICD code picking, match with those codes, meaning if every patient in your clinic is generalized muscle weakness and you've got these patients for 16, 20, 30 visits and research, that alone, like Medicare and the OIG will go, let's pick on generalized muscle weakness for this quarter and do a cert and see how many, and they'll look at evals and see how many evals actually make sense that we created a care plan for generalized muscle weakness. And then when they look at the care plan, they're looking to see, is this a cookie cutter? Did someone use like a copy and paste note to create these? You also need to understand thick codes like 535. If you look at Medicare's guidelines, they're pretty specific about this is not a code to be using on every visit. You train them on ADLs, you show that they understand it, you show compensatory motions and movements, They understand it. You move on until there's maybe a reason to bring it back into the care plan. That's a long audited code, is a 535 used for many, many, many visits. You look at something like a neuro 112. I would say for the number one code that I've seen that's pinged to get people in trouble, it's neuro. And the one thing that I've heard auditors say over and over again, which don't forget, auditors are not therapists, they're nurses. Like I've never met a therapist auditor, I've only met nurse auditors. And so they get taught something by the state or by ACA and they go by it. And what they get taught often is if it doesn't have a primary diagnosis of a neuro condition, hemiplegia with spasticity, Parkinsonism, blah, blah, blah. If it's not a neuro code, it's your primary code that you're pointing to. So when you do billing and you're not pointing to that primary neuro code, they don't want to see neuro re-ed as a treatment. Because if it didn't have a neuro code, why are you doing neuro re-ed? So all of a sudden, if you're doing a lot of neuro re-ed, your diagnosis is not pointing to a lot of neuros, and you go, but Ben, everything I do is neuro re-ed. I go, you're right. Clinically, I think 100% of what we do is neuro re-ed. You read the definition of neuro re-ed, you talk about the fact that we're affecting the afferent and efferent nervous system and the central nervous system. Sure, everything we do has biofeedback. Like, I get it, but the auditors don't necessarily like it that way. And if you read the code very specifically, even if you just read it in Medicare benefit manual, if anyone hasn't read their chapter 7 and 15 for home health and outpatient, it's a pretty easy read, and it really dives deep into this of what Medicare considers normal for documentation and coding. 116 is a hot topic for United Healthcare. I always tell my therapist, if you are getting a person up to walk with them, and I don't see words like, kinematics, foot flat, initial contact, terminal knee extension, if I don't see words like that, and I don't see words like training for touch toe weight bearing, blah, 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 it's not gait training, it's probably functional training, and let's do a 535. If you're specifically stretching someone, if they're counting reps and they're using a weight and they're using a band and they're using a machine, it's probably Therax, it's probably not Theract. If you're doing Theract, but you don't have a justification of doing Theract, just like I was talking about the neuro, it doesn't make it Theract, meaning, a person has I can't even think of a great example, but a really simple something where it really should just be primary focus at the target of the muscle. And we just say that everything, because I said it's functional. I said it's functional, therefore it's functional. Well, functional towards what? You didn't write a single goal towards something functional. I didn't see one transfer goal. I didn't see one IADL goal, but you're telling me that 90% of your treatment's Theract. That's when you start getting looked at. But again, you don't get looked at. Your notes don't get read until your data flags something. So to someone's point of saying, 99% of my codes are 530, I would agree with Daniel. If you don't have some balance in there, like, hey, they should have gotten a CBR by now. But if you don't have some balance in there, you're asking for someone to look at you. And if they're going to look at you, is your eval real tight? Do your diagnosis codes point correctly? Do your treatment codes match what you're saying you're doing? Do they match the evaluation plan of care? So I don't know if that just puts a bow on kind of what that question was, but I know Justin and Tony probably still has a question that he wanted to answer.
Yeah,
So I'll pass it.
Justin, you go ahead there.
So I would like to, I think I would like to disagree with a couple of you guys, but I definitely want to put it back into your court so you can keep this conversation going if necessary. But I think it's an issue that we are just saying that we should tailor our billing around not wanting to raise a flag, I guess you should say. And I personally have never been afraid to fly flags around because I look to the next step and make sure I'm doing it for the right reasons. So, like you said, now if you don't have goals on function and a lot of functional activities, then that's one thing. But if you're doing your job and you're diligent and you're looking at your company's documentation, then hopefully that's not happening. But I see any difference, and Daniel, I don't. This is what I was going to say on your topic. I don't see any difference in a PT changing their coding to try and select a higher paying code, or their coding because they think that it should fit a certain criteria that Medicare wants, whether that's compared to your peers or not. Because I personally don't think we should need to pay attention to what our peers are doing. I think we should research and see what the research says that we are doing what we're supposed to be doing to rehab a certain diagnosis. Now, in my clinics, we are pretty high on 0. Okay, we're probably 6%, probably 40%. Now, through a TPE on, they got 30 charts, and they came back with 100% rate on pass. But my chart. The issue is, but so much of the research, like almost all of the research, when it comes to rehabbing any patients over the age of 60, saying do as many functional strengthening activities. So why are we caring about billing 50% of therapeutic activities when the research is telling us that's what we should be doing with our patients? So bowing down to, if we're listening to Medicare, and Medicare is a slow moving machine, a sloth, that's why are we tailing what our industry is supposed to be cutting edge, and we're supposed to be the tip of on the spear, but we're tailoring what we're doing around a sloth of a gigantic government agency that like you said, Ben, you had a good point, but they're wrong. If they're denying your claim because you don't have a neurodiagnosis like Parkinson's, but you're doing neuromuscular re-education with a patient, that's not our problem. That's their problem. You know, they're wrong.
The problem is, because I would say, I'm trying to say this politely. When I used to consult and I would see someone of your size clinic, I would say you have a lot more to worry about than someone of Tony's size clinic right now. A lot more, like significantly much more to worry about than Tony's clinic, depending on whether you have multiple numbers or one number, whatever. 30 charts for TPE stinks. But if that TPE came back with anything other than 100%, what did that turn into 300 charts? Do you have the time and manpower and money? Let me ask you a question. I think you're sitting at home right now based on the background I'm seeing. Do you write off your home office to the IRS? You do? I can't.
Yeah,
I think you're saying yeah. Because what I would say is I don't, and I literally work from home. I don't, because I just don't feel like being audited by the IRS. I've been told many times that your home office is a bingo thing for the IRS. Like at some point, and that's the thing when we're saying, like you talk about in different parts of the country and different things. At some point, everyone's clinic carries a different amount of risk from different perspectives, even a risk of flooding or risk of whatever. There's different amounts of risk. And then everyone has to have risk tolerance. And if your risk tolerance is, I know I'm doing it right, so bring on the auditors, God bless you, because I've been in front of the auditors many times, and I've been in front of the ALJ, and like I don't wish an audit, even if there's nothing to be found, but you've got an aggressive auditor. I don't wish an audit upon anyone. I don't wish getting out of a focused medical review upon anyone. The time, money, and effort spent, wasted, pulled back, the extrapolations that could be done. I don't know that what you're saying is true, and what I'm saying is true in the sense that I think people have to identify how much risk they're willing to take. And if it's a small clinic, one-person operation, and they feel like I could take some risks, the chances are they probably don't bill enough to generate much risk profiles. But if you got 7, 8, 9, 10 clinics, I would say in Florida, you're one of probably the top 4% risk profiles. I just personally, if you had I don't consult anymore. If you had contracted me to consult and I looked at your entire billing and your entire organization, I don't know that I would say to you, as long as you're doing it right and you think that you can control all these therapists and all their documentation is great, don't worry about it. I would tell you, worry about it. Because even if you're right, it's like fighting the IRS. Like you could be right, but it still will cost you. It doesn't cost the IRS. It doesn't cost the Medicare auditors.
But do you worry about making sure your documentation supports it perfectly, or do you worry about it by just doing what you think you're supposed to be doing?
Well, I'm a big data. I believe that the data going out needs to be first and foremost scrubbed, and then I worry about the documentation.
See you later, Tony. So I guess I certainly understand your point. I just think it's a slippery slope that we should all be having this conversation. And I'm not digging my heels in either. By the way, I'm not saying that I'm not going to go and change, because I've changed 1,000 things with how we do things over the last years. But why? But I think we have to be also having the conversation of why are we reading research if ultimately how we treat our patients is based on how Medicare expects us to.
This is
Why are we
I'll
even
say one more
reading
thing, then I'll drop it because I talked too much already. I think you're confusing best treatment with treatment coding and billing coding, and I don't think they're necessarily one and the same. So like I said, I believe that every single thing I do to a patient is neurologically re-educating their system, but it doesn't fall into the classification of that CPT code the way that the AMA wrote up that language. So I think what you're saying is research shows that we need to be functional with the patient. 100% agree. But I'm just saying when these codes are written, who knows how many, like I honestly don't even know when the AMA came up with half of the 9-second codes.
But it does say it's a therapeutic procedure that uses exercises and takes patients to improve motor control, balance, posture, and other areas. That's based on the AMA's definition. So what?
But then read the
then
read the LCDs and the NCDs, and you'll see the clarification. Just like, you know, I know someone who's billing computerized gait training on every patient because the CPT code says computerized gait analysis. But then if you read the LCDs and the NCDs, they all say it has to be a patient with cerebral palsy and it has to be directed at surgery for cerebral palsy of cutting the Achilles. So it's like the AMA said this is what the CPT code was. I did everything correctly. But then if you read the NCD and the LCD of the insurance companies they're billing it to, they're very specific to say we only cover this if the patient has Parkinson's as a primary or cerebral palsy as a primary diagnosis and there's intention to cut their Achilles for surgery. So, you know, following the AMA is great. Following the CPT definition is great. But if you don't pair that with the Medicare benefit manual or the NCD or LCD of the insurance company that you're going with, it's like half the story.
Sure.
I want to make sure we get to some questions here if anyone has any. Jesse, do you have any questions for us, or Jack as well, or BL as well? And Dwayne, if you have any more questions too. Anyone have anything that they'd like to give voice to here?
I do have a question. So I recently met with a company that's using AI for optimization of codes and documentation and using Medicare guidelines and other guidelines as a litmus test. Is anybody using that, exploring that? Any opinions on that? I know AI is evolving into our world more and more. I just wanted to hear anybody's opinions that might have this.
I wish we would have had this question when Tony was still on because I know he's doing some of that. So
Yeah, Tony is the AI. Yeah, Justin, are you messing with it, Ben?
No.
Even Rafi?
But I would love to hear.
Yeah, I agree. I think it's, when I say it's close, I don't mean it's like 5 years away. I think it's close because, you know, the whole thing about learning modules, like they learn exponentially as more you feed them, the more they learn. So I have a feeling like if we're a year from today, I have a feeling that all of us would be very knowledgeable about it and probably 3/4 of us deploying something like it. So I'm just at the point now where I've demoed 2 or 3. It's really cool. I get it, like especially the ones that are ingesting policies and procedures, and not just ingesting you know, certain cert errors and edits. But yeah, I probably would defer to people who are actually doing it and what they're seeing.
Yeah, I think it's sort of the gray area between the conversation we just had of how do we optimize our coding properly, and if we're going to start using AI, then what side of the fence does that ride on? Of, okay, are we optimizing compared to what Medicare wants, or are we optimizing compared to what we're actually treating with? So it's an interesting conversation to have next year.
Yeah,
I think Daniel.
Jesse,
I was gonna have Daniel chime in because I think he's the only active consultant on this call that still deals with this kind of stuff. But I'm curious your take both on the AI stuff and some of the stuff we've been talking about so far.
Yeah, I've been in this space for a while before it even became popular about 5 years ago. So the blend between what Jesse just said and what Justin said, this is the culmination, right? Is do you want a strategic advantage? However, you still need a clinical decision-making from an operations standpoint to interpret the data, regardless of how good and how smart and how machine learning this fantastic technology is, which I 100% believe in it. I think it's fantastic. I've never met a therapist who likes doing math, first of all. So like doing equations on your billing, nobody wants to do that, right? So I think handing that over, shifting that over, and Ben, you, by the way, just a side note, you put up a great point on, you have to know your reference. And I put the LCD, by the way, for Medicare, which does describe, like for 535, that code, it is specific. It is very unique that, yes, it's a fantastic code. It diversifies really well, but you're only expected using it, right, for 1, 2, 3 maybe visits just to get people started. But Jesse, the idea is that, yes, I think we should be embracing this. But the idea is that you have to be knowledgeable about what to do with it, right? You have to make decisions based on this kind of, yes, I approve or I do not approve, based on your clinical rationale, right? That's really what it comes down to. And the more real time we see this, I think the better. So I really don't think that we should be looking at this retrospectively. I think, very soon we'll be seeing in real time that therapists will be able to say, hey, by the way, this is what I was given. First of all, I don't know why EMRs haven't done this years ago. Sorry, Paul. But like, really, we should be seeing, hey, by the way, these are your 4 options. These are your best, diversified billing options based on what you told us you did. Because again, you're still justifying your skilled care. And the question is, does that make sense mathematically? And we don't want to figure that out. We should have help doing that, in my opinion, from a compliance standpoint.
Yeah, and from like a risk mitigation standpoint as well, like you want to make sure that the clinical decision making is not being completely handed over to the AI, right? Because that's kind of the big deal. Like a big distinction for a lot of regulators. And all that. Yeah.
Jesse, any more questions on your end? Good. Cool.
Good. Thank you.
Awesome. Greg or Jack, anything from you guys? I know we're wrapping up here. We got a couple minutes. Anything else? No. Well, let me get one more question in here. And Daniel, this might be a question for you that was submitted beforehand, but it says, I've heard from my previous employer that we should not bill gate CPT code a lot because it will trigger an audit. Is that true or false? And I know that's a very general question, it seems like, but curious on your take.
I don't know. As the therapist in me, I'm thinking we're moving experts. So I'm not a fan of someone saying don't bill gate training, which is unique to us as an industry. I would never tell someone that personally. Again, it's all about, does the definition make sense? Does your LCD and contractual obligation definition, right? It's about educating the staff. So what Justin said really stuck with me, that, yeah, you may thrive on a 30 chart review, which is fantastic. But the average therapist that I'm dealing with, they're not thriving when it comes to these audits. They're just going, oh my God, I didn't know what that definition meant. I wasn't sure what the rules were. I was just trying to improve my patient sitting in front of me. And that's really that's why we got into this business. But that's the challenge, that unless we're reflecting what we're doing in a manner that is not raising flags unnecessarily, I think that's what we should strive for. It's not that we're bending to anybody. It's simply, we could do both at the same time. We could still provide excellent care and also maximize and really use technology to help us when it comes to the coding and billing stuff that we don't want to do.
Sure.
So is the choice the way I'm hearing it and the way I'm looking at it from a director standpoint is, do I try and find staff, and then maybe this is impossible, do I try and find a team that is willing to learn the intricate coding, CPT, and being able to document what they're doing effectively to where it would stand up in the case of an audit? Or do I not worry about that, but just make sure they fly under the radar and don't trigger any red flags from Medicare? Maybe it's a combination of both, but isn't it something that we could also build into isn't there a technological thing we could solve this with? Could we make sure that we include the justification into the exercise that we choose and educate our team that if you're going to do gate training, make sure you're doing it with patients because they're going to benefit from gate training, and then make sure when you gate training that it's forcing you to justify it in your documentation. Because I think a lot of times the therapists, I mean, to give credit, they think in their head they justify it. It just doesn't make it onto the actual record. So is there a technological solution with the EMR that you use? Can you build that out more robustly to where it has it all just baked in there when they pick that exercise? I don't know. I wasn't just saying that, but if anyone
Well, I think there are
says yes or
tools
no,
that are
that's a
getting
bad
built
idea.
that will do that or will help in that. I think the big thing, to Ben's point earlier, he was talking about kind of leading with the data. I think you do, from a director standpoint, you do need to make that data very transparent to your team and kind of just show them what that data tells you or what an auditor might think about that data. And then have those conversations with your team members about, coding appropriateness, clinical effectiveness, clinical decision making, documenting all that. But leading with the data is very important, because you don't want your team either to think like, oh, he's just doing this because he doesn't want to get audited or because he wants to maximize revenue. You need to give them the why and saying, listen, everything you're billing is putting up a flag. So we need to go and either double check everything you're doing and make sure that your T's are crossed, your I's are dotted, or something's got to change. But framing it with the data and being transparent about it also helps. Like, yeah, it is incumbent upon the clinicians to learn some of that as well and to implement it in their coding and documentation.
One question I always get a lot from my PT, every time I hire a PT, some questions I ask them, how do you, how would you build this? What's your justification? How would you code this? And to see kind of where their baseline knowledge is on these topics. How would you, especially Daniel, what extent, if any, is there any overlap on these CPT codes? And is there a possible way to make it black and white for the therapists?
I'm not sure. That's a good question. But again, I said it in the beginning, I'll say it again. I love proving education. So it's all about constant, on a routine basis, educating your staff in a meaningful way. So let's just talk, like, for instance, something that has nothing to do with what we're talking about, OSHA, right? We don't buy a class for our staff that talks about, steel toe boots and hard hats, right? We have something that's effective for our clinic, something that's relevant to us. Same thing with training. It has to be content that is unique to you and in your setting. So a lot of the stuff where we're talking about, the wrong setting type and we're trying to just get by, I think if we focus on onboarding and really getting people bought into the whole concept of, hey, by the way, the more you know, the better outcome you're going to get. And by the way, you're not going to have to deal with Ben or myself later on when it comes down to, that was nice that you passed a 30, but let's say they extrapolate to your point, or let's say you don't get 100%. That under 10, 15% ratio really becomes a problem for a lot of people, not just time, but money and resources that have to go into just dealing with the auditor, right? So I think that's part of the challenge, that if you could prevent this on the front end just with really great training and content, that I usually don't hear staff saying, you know what, my training is fantastic. And it's leveling the playing field too. So when you have performance reviews, there is no question of, hey, by the way, what am I expected to do? We already told you exactly what you're expected to do. We trained you on it, right? So the idea is that you're really leveling the expectation of saying, hey, by the way, this is exactly what you need to do. And we're not going to have a conversation next month about it. This is something that we've already discussed and you already have the tools to be successful with.
Awesome. Well, we're coming up on time here. Thank you everyone for joining. A lot of our experts today, Justin, Ben, Daniel, Rafi, have all been on Strata Studio. So for those who haven't been on it or listened to the podcast, there's a ton of great resources there. These guys have all been on at least once, if not multiple times. So if anyone has any questions and wants to learn more about Strata PT as well, feel free to hit up Corey. I'm sure she'll be sending everyone the recording as well, so we can go back and listen to anything. But thank you for everyone's time. And if you have any questions, always feel free to reach out to us.
Thank you, guys. I think it's awesome having a bunch of people and that can talk about this stuff critically. These are the conversations that need to happen, like, very often in order for us to advance in profession. PT for sure.
Totally. Thank you, everyone. Have a wonderful week. We'll talk to you guys soon. See ya.
All right. Bye, guys.